So we'll begin with endocrine now. So most important and most commonly asked in ICU, that is the practical aspects. Okay, glucose control in ICU. So it is very, very important. So is glucose control important at all? What are the risks and complications and what are we worried about? So it is just not hyperglycemia that we are worried about. It is also about the glycemic variability. Okay. The variation or fluctuations in glucose level, that is also very important. And hypoglycemia is another important concern. So why is hyperglycemia important or the adverse effects of hyperglycemia? Hyperglycemia increases mortality and morbidity, increases the risks of infections, acute renal failure. It increases the mechanical ventilation in hospital day and cardiovascular complications. Glycemic variability increases mortality and adverse outcome because of high oxidative stress and endothelial damage. Hypoglycemia, it is a very important concern. Very low glucose or sugar levels increases mortality. It not only increases the mortality, if not treated in appropriately or immediately, can result in permanent neurological damage, can result in seizures, arrhythmias, SIRS response, and it will inhibit the corticosteroid response to stress as well, and it impairs the sympathetic nervous system responsiveness, causes cerebral vasodilatation. So patients who are hypoglycemics, who do not receive appropriate timely treatment, will have neuroglycopenic symptoms that can last for a long time. Okay. So causes of hyperglycemia in the ICU, it could be due to three factors. One, stress per se. It increases the cortisol catecholamines. So there is high counter-regulatory hormones that are increased, and there will be insulin resistance. So this is one mechanism. Second, increase in the cytokine levels. This is also one of the counter-regulatory hormones, cytokines, tumor necrosis factor alpha, contributing to insulin resistance. Third, the nutritional aspect might be compromised. The nutritional aspect also plays an important role, especially the parenteral nutrition. So these are the three important factors. So the patients with hyperglycemia, you can classify into three categories: patients with known diabetes, unknown diabetes mellitus, and new onset hyperglycemia. So how do you differentiate between these three? So known with a history, and you have already a criteria. You're fasting more than 126, postprandial more than 200, HbA1c more than 6.5, classical symptoms of hyperglycemic crisis. Undiagnosed, you go with a HbA1c more than 6.5 and a blood glucose more than 140. Okay. And new onset, here the HbA1c is going to be low, and it is predominantly due to stress induced as well as extrinsically admitted because of your catecholamines. You'll be giving a lot of vasopressors, adrenaline infusion, steroids, and parenteral nutrition coupled with insulin resistance. So these are the main reasons. There will be enhanced lipolysis, glycogenolysis, and gluconeogenesis. So remember, compared to the diabetes and the undiagnosed diabetes, these patients who have a new onset hyperglycemia have threefold higher mortality. So what is the range that you need to maintain the glucose control, glycemic control in the ICU? So we have a target of 140 to 180. How did we arrive at what is the trials and how did we come to a conclusion of this? So this is something you'll be asked in many of your practical exams or your bedside discussions. So everybody will be doing this. It will be a rapid revision that I'll be going through. So first will be a Vandenberg et al. Trial that is in 2001, also known as the Leuven-1 trial. This was done in mainly cardiac surgical patients, wherein they compared intense insulin therapy to conventional glucose management. Here, the targets of intense insulin therapy was 80 to 100, whereas conventional was 180 to 200. They found that the intense insulin therapy showed a significant decrease in mortality. It was beneficial, okay? Decrease in ICU as well as hospital mortality. So it was 4.6% versus 8%. It also decreases the critical care illness related polyneuropathy, bloodstream infections, renal replacement needs. So all these things were decreased. Next came the Leuven trial. So these were predominantly in cardiac surgery patients. When they tried to replicate this in the medical ICU, that was in 2006, they did not find any benefit in mortality. But okay, the difference was 37.3 versus 40. Okay, this was the difference, and there was no significant difference. But the patients in intense insulin therapy had more incidence of hypoglycemia. So the incidence of hypoglycemia was almost 18.7%. So this was something that was alarming. So next two trials were done. The glue control in 2009. This also found the increased incidence of hypoglycemia in patients who received intense intense insulin therapy. Next was the WISE-UP study. This also showed the risk of adverse events related to hypoglycemia. So then came the NICE sugar study that was in 2009. This was done, and this was a multi-center trial in medical and surgical ICUs where they compared intense insulin therapy 80 to 108 and conventional was less than 180. So they found there was increase in the mortality in severe and severe hypoglycemia. So they found it was not only ineffective, but it was harmful. So they did not they did not recommend a tight glucose control for hyperglycemia. Okay, so this is how we arrived at. And the next studies were COIDS, that is corticosteroid corticosteroid treatment and intense insulin therapy for septic shock in adults. So this also did not find any mortality. So as per the American Diabetes Association, so we follow the 140 to 180 glycemic targets. So that's about it. So next topic will be on diabetic ketoacidosis. So this is a very easy topic. So I have combined both of the ADA, American Diabetes Association, and the Joint British Diabetes Society, both the guidelines together. Okay, the definition of DK as per the ADA, that is American Diabetes Association criteria, will be this. The triad DKA triad involves metabolic acidosis, ketosis, and uncontrolled blood sugar. So as per ADA, blood glucose more than 250 grams per deciliter, milligrams per deciliter, arterial pH less than 7.5, bicarbonate less than 18, anion gap more than 12, a positive serum or urine ketone, that is a serum ketone more than 3 millimoles per liter. So this is the criteria as per the ADA. As per Joint British Diabetes Society, so you remember D, K and A. So here the glucose levels more than 198. K for ketonemia, that is more than 3 millimoles per liter of ketones, or a urine ketone dipstick, that is 2 plus positive, and a bicarb level less than 15 or a pH less than 7.5. Here the anion gap is not included. That is the difference between these two, and the blood sugar levels are slightly different. So in incidence, children mostly type 1, adults mostly type 2. The case fatality rate is less than 1%. So mortality increases with the age as well as comorbids. Coming to the pathophysiology. So there can be an absolute insulin deficiency. Mostly in the ICUs, it is going to be a relative deficiency. So relative insulin deficiency with increase in the because of stress, also extrinsically administered vasopressors, catecholamines, so counter-regulatory hormones will go up. So there is a imbalance between insulin and counter-regulatory hormones. Decrease in insulin causes increased lipolysis, increased free plasma fatty acids, increased hepatic free fatty acids. Okay, because of these fatty acids, there is more ketone production, and these ketones are neutralized by buffers, nothing but bicarbonate. So as the bicarbonate buffers the ketones, the bicarbonate levels goes down. This results in high anion gap metabolic acidosis. Also, because of increase in glucagon level, there is increase in carnitine palmitoid transferase. So this also causes ketosis. So the other thing is because of increase in the counter-regulatory hormones, there is increased gluconeogenesis, there's decreased glucose utilization and increased glycogenolysis. Okay, glycogen is broken down. There's new production of glucose and utilization is also impaired. Because of all these three mechanisms, there is hyperglycemia. So due to hyperglycemia, there is increased hyperosmolality. So due to hyperosmolality, there is diuresis that goes on. There is osmotic diuresis because the renal threshold for the sugar levels will be it will exceed the renal threshold, so there will be glycosuria because along with sugars there will be water that is carried away, so there is osmotic diuresis. Because of osmotic diuresis, patient will be volume depleted, hypovolemic, and there will be loss of electrolytes along with the water. So, and because of hyperosmolality, it affects the brain. So, there will be depressed mental status. So, this is the main pathophysiology of DKA. So, we have looked into the pathophysiology, and also because of hypovolemia, there will be impaired tissue perfusion, increased lactate. So, what are the ketones, predominant ketones? Beta hydroxybutyrate, acetone, and acetate. Okay, these are the three ketones that are produced in DKA. So, triggers of DKA, just remember any inciting event. Mostly it can be non-compliance to the already the patient might be non-compliant to the drugs, or it could be a new onset diabetes or infection, stroke, trauma, any surgery, alcohol, alcohol intake, myocardial infarction, or any other stress factor. Okay, or any sympathomimeric drugs, thiazides, so all these things can cause steroids. So other two important factors that you need to remember is SGL2 inhibitors. So these are gaining more importance these days. That is dapagliflozin, empagliflozin, and canagliflozin. So these drugs cause euglycemic decay. Also, the immune checkpoint inhibitors, anti-cancer drugs like pembrolizumab, nivolumab, and ipilimumab. So these drugs also cause decay. Symptoms usually polyuria, polydipsia, mental obtundation, abdominal pain, dehydration, acetone breath, and cosmol breathing. So these are the symptoms. Differentiate between euglycemic DKA and HSS. Euglycemic sugar levels are almost in the normal range with acidosis, pH less than 7.3, bicarb less than 18, ketonemia will be there. So this is mainly imbalance between insulin and counter-regulatory hormone with a raised glucagon and insulin ratio. The ratio between glucagon and insulin will change. Okay, this happens mainly due to recent use of SGLT2 inhibitors. It can also happen in pregnancy, surgery, or any kind of gastroparesis, ketogenic diet, alcohol intake, any fasting state. So this can happen. Criteria for HHS is a plasma glucose level more than 600. Okay, and the serum osmolality should be more than 320 milliosmoles per kg. Because of significant raise in the glucose level and high osmolality, so there is osmotic diuresis which has happened, and there will be profound dehydration with an average deficit of about 9 liters. And the pH is usually, there's no acidosis. Mainly it is due to the symptoms are mainly due to hyperosmolality. So usually acidosis may not be there, or even if it's there, it will be mild. So pH is usually more than 7.3, bicarb more than 15. Small ketonuria can be present. So there will be alterations in the mental status of the patient as well. So these are the various definitions. So comparing between DKA and HHS, we already looked into. So in terms of the type, DKA usually type 1 occurs, it mainly occurs in type 1. HHS usually in type 2. The onset is usually rapid and usually within 24 hours, whereas in HHS it is usually insidious over several days. The fluid deficit is almost 6 liters. Here it's a very huge deficit, 8 to 10 liters. The blood glucose levels, modest hyperglycemia will be there. Here severe hyperglycemia more than 600. The key metabolic disturbance is metabolic acidosis, serum, ketones. Here it is hyperosmolality more than 320 milliosmoles per kg. Clinical features, abdominal pain, cosmal respiration, fruity odor, hypotension, tachycardia, and drowsiness. Here, because of the volume deficit, hypotension, poor skin turgor, tissue perfusion deficit, there can be tachycardia and altered mental status. Okay. The mortality is very high in HHS compared to DKA. So how will you treat? First, categorization of decay, mild, moderate, and severe. This is based on the pH bicarbonate anion gap. Okay, usually if the pH is between 7.25 to 7.3, bicarbonate between 15 to 18, and the anion gap is more than 10, it is classified as mild DKA, wherein the patient is alert. Moderate, if the pH goes down even more, 7 to 7.25, the bicarbonate is 10 to 15, and the anion gap is more than 12. Patient is alert, but can be drowsy as well. Severe pH less than 7, bicarbonate less than 10, anion gap more than 12, patient is in stupor or coma. So this is the classification of DKA. When you're managing a patient, investigations that you need to look into, one, DKA related and other precipitating factors. DKA related, what all you will do? Serum glucose, HbA1c, electrolytes, acid-base gases, ketones, and urine analysis looking for ketones by dipstick. This is related to DKA. And also this can cause AKI. So remember blood urea nitrogen and creatinine and other serum electrolytes, because you are more worried about potassium before starting your insulin. So electrolytes. And along with that, other investigations which will help investigating your cause depending on the patient history, ECG, echo, or ruling out infections. So any other x-rays or any cultures. So depending on to rule out your inciting event. So that you need to do. First, how will you manage? First and foremost will be maintain your airway breathing circulation. Volume repletion is the first factor that you need to do. So after you give adequate fluids, what fluid to give, how much to give. So that is our concern now. So intravenous fluids remain the first modality of treatment. So you start with what fluid? Most of the guidelines have recommended 0.9% sodium chloride. But what is the problem with large volume resuscitation of normal saline is that we are more worried about the hyperchloremic acidosis, and then the high that is you're worried about the AKI. So as per the SCOPE DKA study, balance salt solutions have shown faster resolution of acidosis and lesser length of hospital stay with acetone-based balanced salt solutions. So the balanced salt solutions are preferred, as well as SMART and SALT ED trials have shown that balanced salt solutions compared to normal saline have benefit, okay, because this can lead to hyperchloremic metabolic acidosis. So how much to give? 15 to 20 ml per kg in the first hour to start with. So first, after correcting the fluid deficit, then look at the potassium levels before starting your insulin. So the potassium levels should be at least 3.3 millimoles before starting insulin, because if you start insulin, there can be a intracellular transcellular shift of the potassium resulting in hypokalemia and adverse events, arrhythmias related to significant hypokalemia. So you need to be worried about, and always replace potassium 30 to 40 millimoles intravenously in every volume of fluid, like every unit of uh, um, fluid that you're going to be giving. So depending on the levels, like if it is 3.3, you supplement 30 to 40 until your serum potassium is more than 3.3. If it is 3.3, between 5, you have to give 20 milliequivalents in every liter. If it's more than 4, do not supplement. So this is the guideline. Next is starting your insulin. So how much to give? So always avoid a priming. Initial conventional recommendation was to give in a bolus, but these days the recommendation is to start on an infusion directly, 0.1 unit per kg per hour, followed by and you have to continue based on your blood sugar levels. So if the sugar levels drop to less than 250 milligrams per deciliter, then you have to add either a dextrose based solution to avoid hypoglycemia. So, and you have to maintain a target between 140 to 200 until the anion gap is closed, that is less than 12 milliequivalents. So once you start insulin, you monitor your insulin infusion, monitor your sugars hourly, and if it's less than 200, add on a dextrose based solution, continue insulin infusion until the acidosis resolves, your anion gap is closed. Okay, you can start on a long acting insulin simultaneously as well. The recommendation is 0.25 unit per kg of long acting insulin. So how frequently you need to monitor? So glucose measured hourly, serum electrolytes, ABG, anion gap. So all these things second to fourth hourly, depending on the patient status. And then you can monitor the beta hydroxybutyrate. The point of care testing wherein we use the method to measure at the bedside, that uses the beta hydroxybutyrate, wherein the urine levels measures the other acetone, acetoacetates, and beta hydroxybutyrate as well. So remember that as well. So bicarbonate, is there any use of bicarbonate? Bicarbonate is controversial. Only if the pH is less than 6.9, you can start on, you can give a bicarbonate. That too, how much needs to be given? So this is an isobicarb infusion. A 5% dextrose 400 ml with 100 ml of soda bicarb can be added, and it can be given at a rate of 200 ml for first 2 hours until the pH. So you continue this infusion until the pH is more than 7. So that is the AD. So this is usually as per consensus statement. This is not as per any guidelines. ADA guidelines do not recommend the use of soda bicarb until the pH is less than 7.5. So what is the adverse effect of bicarbonate? It can result in paradoxical cerebrospinal CSF acidosis, cerebral edema, sodium overload, and hypokalemia. So that is why you have to avoid it. So complications of decay related, treatment related, mostly fluid resuscitation. When you are resuscitating the fluid, especially in pediatric population, the most important thing that you need to be worried about is cerebral edema, pulmonary edema, cardiac dysarrhythmias related to hypokalemia, and hypoglycemia. So how much reduction in the blood glucose levels that you have to target? 50 to 75 milligram per deciliter per hour, and a ketone reduction of 0.5 millimoles per liter per hour. So, and a increase in venous bicarbonate by 3 millimoles. So this is your targets or your response to therapy. So decrease in blood glucose levels, reduction in the blood ketone, and increase in your venous bicarb. So other targets is maintaining your good urine output, potassium concentration between normal level 4 to 5, and then reduction in your plasma anion gap. So the other differentials for DKA would be other causes for acidosis, uremia, lactic acidosis, glycosis, starvation ketosis, alcohol, and salicylate. So how do you identify resolution? As per the Joint British Diabetes Society, so if the pH is more than 7.5, 7.3, bicarbonate more than 15, ketone levels less than 0.6. So this is the criteria as per the Joint British Diabetes Society. Americans 7.3 pH, more than 15 bicarbonate, anion gap less than. So here they mention the ketones, whereas the Americans mention the anion gap. So resolution of HHS is mainly the sensorium improvement. Okay, improvement in the GCS, blood glucose levels less than 250, and serum osmolality less than 310. So this is the timeline of management. So within 0 to 60 minutes, diagnose, resuscitate, immediate management. So looking for pH, first fluids, electrolytes, start insulin, and check in for your blood gases, serum ketones, pH, and all that. 1 to 6 hours, suppression of hyperglycemia, ketogenesis, and organ support if needed. And again, reassess all the values. 6 to 12 hours, monitor response to treatment, watch for complications. Okay, look at the mental status. That is, patient might be going into cerebral edema. So here, suppression of ketosis happens. So 12 to 24 hours, that is a period wherein your DKA resolves, resolution of DKA, and you start transition of intravenous insulin to a subcutaneous form. Convert to a subcutaneous form, and then again watch for rebound hyperglycemia and ketosis. So this is the complete algorithm of how you need to manage. We have talked about this in detail. Okay. So bicarbonate, if pH is less than 6.5, 6.9, and you'll have to monitor every second hourly. Insulin, the difference in DKA and HSS management is that the insulin infusion started at 0.14 unit per kg. And then if the levels drop to in DKA, if it is less than 200, you start a dextrose-based solution. So here, if it is reaching less than 300, what you do is you reduce the insulin levels, and then you consider glucose-based solution, maintaining between 200 to 300. Here below 200, you add on dextrose base. Here between 200 to 300, you add on dextrose base solution. So after resolution, you always bridge over. You start the subcutaneous insulin, and after 1 or 2 hours, then you discontinue the intravenous form. Okay, potassium supplementation that we already looked into. So that is about management of DKA and HHS.